is going to talk about it. He's currently Professor of Medicine and Professor of Healthcare Policy and Research at Weill Cornell Medical College in New York and Qatar. His work, education, and training experience spans several countries over 5 continents. He's also received the Abu Dhabi Health Services Company Excellence in Research Award, HMC Qatar Excellence in Health Services Research Award, and multiple other national and international awards. So, without further ado, sir, please take over for your lecture. Thank you.
Recently, he is the member of the National Health Research Board. He is also starting a new chapter of American College of Physicians. He has extensive work on the COVID. I was just going through that. Only on COVID, he has 13 publications in New England Journal of Medicine, which itself is a record. A very warm welcome, Dr. Bhatt.
Thank you, sir. And I would like to thank PSIM and its leadership for inviting me to this prestigious gathering. I have only 20 minutes to talk about COVID updates. We can take about 5 days to talk about what's going on with COVID. So because the talk is limited to about 20 minutes, I'm going to limit myself to a few things. These are my disclosures. The one in green are my active current fundings, but I have no conflict related to my talk today. So because of the time constraints, I'm going to try to answer 4 common questions which we get asked frequently. And those 4 questions are, is the pandemic really over? So that's the first question. Second question is that, what is the significance of all these variants that we hear about? Does it really matter if someone is infected with the wild type versus alpha, beta, delta, omicron, and now the subvariants of omicron? The third question will be about how many doses of vaccine are really enough? Do we need a 4th dose or a 5th dose, or annual doses or semi-annual doses? And finally, we'll talk about what long COVID is, a brief description of long COVID, and if there is anything we can do about that. To answer the first question, or before we start, first things first, where is the data coming from that I'm going to share with you and base my assertions on? So our teams have done extensive work. We have published about 75 papers on COVID from Qatar and from the United States. And we've created large data sets for COVID research. And we've created these, Dr. Sin pointed out the creation of data sets in various parts. So we have also created very large data sets which have been used extensively for research, but as well as for policy making. And this is how we do that. We combine many different existing databases or places of information into one data set, and then we analyze that. And the type of studies we have done from these are health services and access studies. In other words, how many people got COVID, how many people were, how many people presented to hospitals with COVID, and did the pattern of presentation to hospitals change over a period of time. A large bulk of our work was related to vaccine effectiveness. We have worked a fair amount on breakthrough infections, their severity and their consequences, and the severity of illness related to various variants of concern. Let's tackle the first question, and we talked about, has the WHO really called it the pandemic to be over? So WHO in May of this year actually said that COVID-19 is no longer a global health emergency of international concern. So they haven't used the specific word of removing the pandemic label for that, but some individual countries have downgraded, or actually many individual countries have downgraded the pandemic from a major emergency to, as others were pointing out, to more of an endemic disease in their countries. But in the last couple of months, there has been a resurgence of cases across the globe, and these are a few of the headlines from the largest newspapers in the US, for example. And the same pattern is observed in many other countries. The numbers have gone up. And I use this maxim, it ain't over till it's over, from this famous baseball player in the US who used this term in early 1900s, and it stuck in the common folklore in the US now. If you look at the daily new cases, as you showed earlier on, Professor Sin, that the number of cases have gone down dramatically in the last few months. There has been a small uptick of cases very recently, but when you compare that, when you look at the epidemic curve over the last 2 or 3 years or so, this uptick is relatively small. The same is true for the number of deaths. There is a small uptick of deaths, but if you look at it in the larger picture, this uptick is relatively small. It is nothing close to what we saw in the Delta wave or even in the Omicron wave, which was much less severe, as we will talk about. But the current wave that is coming out is much, much smaller than that. So in summary, the answer to that question is yes, maybe we should be very vigilant. But in my mind, it hasn't risen to the point that we go back to the pandemic era preparation or pandemic era response. We always need to be vigilant about this thing. The second question is, what about different variants of concern? Now, as you know, variants are types of virus which evolve over a period of time due to antigenic drifts and shifts and changes in its genetic composition. And the reason they are important is because these genetic variations can transform the virus into a more virulent form or a more infectious form. On one hand, these genetic changes can do that, but it is also possible that some mutations may make the virus less virulent and less transmissible. But what we fear about is the first one, that the virus may become more virulent because the virus is always under pressure to evolve and become more efficient in transmission and in its pathogenicity. Now, this graph or this slide shows the current variants of concern that are circulating in the US. And the reason I show is not because you need to know which variants are prevalent right now, but the fact that these are changing constantly over a period of time. And while the changes from 1 month to the next month are not dramatic, the fear that we always have as infectious disease doctors, epidemiologists, and public health officials is that one of these genetic mutations may become transformative for the virus to make it very, very lethal or very, very infectious, as it happened with the Delta wave or with the Omicron wave. Delta wave was much more lethal or much more severe. Omicron wave was much more infective, and we will share that data. Now, why is this also important? Because if you look at the R0, and I'm sure everyone is familiar with the concept of R0, it is the measure of infectiousness of a virus. In other words, how many subsequent infections can be expected from one infected person. So if you have an R0 of approximately 5 or so, which was the R0 or R0 for the Delta virus, the 10 cycles of transmission in a completely vulnerable population, and I emphasize, in a completely vulnerable or a non-immune population, would lead to 48 million cases. And if the incubation period is small, in a matter of days, a completely new population can have 48 million cases from one case. If the R0 goes up to about 9 or so, which was the median for Omicron, 10 cycles of transmission will lead to 31 billion cases, which is much more than the population of this earth anyway. But again, these are mathematical calculations in a non-immune population. Fortunately, what happens is when there are first wave of cases, some people develop natural immunity, other people get vaccinated if you have an effective vaccine and so forth. We also institute a lot of measures to prevent the transmission or to prevent the population who's vulnerable from getting infected. For example, masking, social distancing, all those things reduce these numbers dramatically. But the basic biology and the reason for our fear of a high R0 and evolution of viruses is this, that in a very short period of time, the whole world can be infected if it's a brand new virus to which the world's population is non-immune. Now, the other reason why this is important is because the severity of illness differs by the variant of concern that is infected the person. Again, these are a series of studies done by our group across the globe. We found that the Delta was much more severe in terms of outcomes than the Omicron variant. In other words, if you got infected in the Delta era or with the Delta virus, Delta variant, you were much likely to be hospitalized or develop critical disease or die from it. Omicron was much more infectious, but was much less lethal or severe in terms of its consequences. When we compared Delta with the earlier variant, the Beta variant, Delta was much more serious than the Beta variant as well. And again, the epidemic curves that I showed you earlier on also show that trend. Another important reason why variants are important is the vaccine effectiveness varies depending on which variant has been circulating in your population. And again, we did a series of studies published in numerous journals, including New England Journal of Medicine, Nature Medicine, and others. We showed that different variants of the virus have varying level of response and effectiveness against the vaccines that were prevalent. So on your left side, you can see that the effectiveness of vaccine against any infection goes significantly down as you progress through the variants from alpha to beta to delta and so on and so forth. And it goes down both for the mRNA vaccine, which was more effective in our studies, but also for the other Moderna vaccine. The vaccine effectiveness against severe and critical disease, fortunately, was not much of a concern, because these vaccines were so effective against preventing critical disease that we hardly ever saw people dying or ending up in the ICU if they were properly vaccinated. It is also important because vaccine effectiveness drops over time. And again, we did a series of elegant studies in both countries, in Qatar and in the US, that shows that over a period of 5 to 6 months, the vaccine effectiveness for both infection, subsequent infection, as well as for critical and severe disease drops dramatically. So our studies have shown that at about 5 to 6 month time period, your protection from vaccines has gone down dramatically, that you may require either another dose of vaccine or some other form of immune building for yourself. Again, the fortunate thing was that the drop in protection from severe or critical disease was not as severe. So what we saw was that vaccine effectiveness for infection, prevention of infection, dropped to about 20% from a high of about 80 to 90% in the first month. So at 5 or 6 months, you were only 20 to 25% protected against reinfection. However, against severe or critical disease, your protection was still in the range of 50 to 60% or so. And this shows the same thing in people who develop reinfection or breakthrough infection after being vaccinated. So if you're vaccinated, and it also varies by which variant you were infected with, the protection is much better if you had been vaccinated versus if you developed a natural first infection. So now let's move on to the number of vaccine doses. And there has been a lot of concern in the general public about how many doses should I get? When will this end? Do I need these vaccines for the rest of my life, and so forth? So I summarized this data earlier on about a minute ago, that your vaccine effectiveness drops dramatically at about month 5 or 6 or so to about 20% or so. So you're very prone to getting reinfected if you are exposed to the virus again. But again, like I showed, that the protection against severe and critical disease is still reasonably good at about 55 to 60% or so. So vaccine is still very, very effective, although at about 6 months or so, we need to start thinking about what else to do. And this is just showing the same in a different format. And we also showed the survival rate in people who got 3 doses versus 2 doses over a period of time. And all the studies showed that 3 doses were significantly more protective than 2 doses, both for infection and for severe or critical disease. So I think there is no question that 3 doses, which what we call the first booster, was very effective in preventing a lot of consequences, serious consequences of COVID-19. Then comes the question about the 4th dose. And more recently, studies have shown, and this is one of the studies that is not from our group, that people who got the 4th dose, again, were much better protected against reinfection, against symptomatic disease, against hospitalization due to COVID, against severe or critical disease, in other words, ending up in the ICU or on mechanical ventilation, or dying from it. So the protection ranged from 52% for confirmed reinfection to about 76% for death. So 4 doses obviously were significantly better than 3 doses. And again, other studies have confirmed this, that when you don't get the 4th dose, your risk of consequences or severe disease are much higher. Now, this also depends on which variant you were infected with, and I'm not going to go into the details of these studies that we published. There was a series of studies where we compared the different variants and whether they got 3 doses or a booster or no booster, and there was definitely better survival and better outcomes in patients who got the booster, and it was better for people who were infected with the Omicron variant. So in latest news, last week, FDA granted full approval for next round of boosters to all individuals, all persons who are 12 years and older, and they authorized this for people who are 6 months to 11 years old. So now there's a clear indication and a clear guidance from the FDA, and CDC, which is the public health arm in the US, is very likely to approve this in the next few days, that everyone should get boosters going forward. Now, one thing I want to caution is that while boosters and regular doses of the vaccine provide very significant protection compared to not getting these doses, the absolute difference between the two is relatively very small, because the overall mortality and severity of illness from COVID has gone down very dramatically. I think that is one of the reasons why we have become so complacent that we don't see the number of deaths and number of ICU admissions and number of people being on mechanical ventilation, what we saw with the Delta variant, for example, or even with the Omicron variant. So people have become complacent, and the number of deaths overall in absolute terms has not gone up, but the relative difference in people in no boosters versus repeated boosters is quite significant. So finally, a few minutes or 2 or 3 minutes about what long COVID is. So the UK National Institute for Healthcare Excellence defines long COVID as having signs and symptoms that develop during or after a COVID infection, which continue for more than 4 weeks and are not explained by any other or any alternative diagnosis. And they divide that into 2 groups, actually. They call one as an ongoing symptomatic COVID, where the symptoms never resolved and kept on going for about 4 weeks to 12 weeks or 1 month to 3 months. And people who develop a post-COVID syndrome or post-acute COVID syndrome, that is a new term for that, where symptoms persist beyond 12 weeks or so, or may even come after a while of initially getting better and then the symptoms coming back. WHO has a kind of a similar definition, where symptoms last for more than 2 months, and the important part again is that they cannot be explained by any other illness. The risk of developing long COVID and its specific symptom constellation is unclear, but I'll go over some of the data that we have. And the difficulty is that many of those symptoms are encountered very commonly because of other conditions, and may be very, very difficult to differentiate whether it is a post-COVID phenomenon or is it something else that you have gotten which explains those symptoms. So the 4 most common symptoms that have been associated with long COVID are fatigue, neuropsychiatric disorders including memory problems and concentration issues, and respiratory problems like dyspnea, shortness of breath, and cough. The risk factors for developing long COVID include being unvaccinated. So we come back to this theme again and again, that vaccination is really, really, really very important in preventing all sorts of complications of COVID-19. People who were older at the time when they first got COVID, for some inexplicable reason, women are more likely to get long COVID symptoms. Symptom severity at the time of original presentation, or increasing number of symptoms when you presented originally with COVID, pre-existing asthma, and presence of other multiple medical comorbidities all increase your risk of developing long COVID. And this graph on the other side of this slide kind of nicely summarizes the prevalence or incidence of those conditions. In various studies, it's generally anywhere between 25 to 40% of the individuals who have COVID may end up having at least one or more of the long COVID symptoms. So that is a very, very high prevalence of long COVID. And again, there are the 4 cardinal ones I mentioned earlier, which are respiratory, neuropsychiatric, the 2 neuropsychiatric ones, and fatigue. But there are other conditions as well that are associated with long COVID. These are GI problems. Dr. Omar, you would be interested in some of those. People have ongoing diarrhea, abdominal pain, nausea, bloating. Fortunately, it's less common than the respiratory symptoms or generalized fatigue. People have ongoing musculoskeletal system complaints like joint pains and myalgias. Cardiovascular symptoms have been reported in some of these individuals, and this is different than the risk of cardiovascular disease that we have heard about. For example, increased risk of myocarditis with acute COVID. So this we're talking about long-term effects of COVID. How to differentiate or diagnose that? So first important thing is that you rule out everything else, and that may be very, very difficult, because if you just have fatigue, there is no one single test that you can say that fatigue is that can explain why a person is having fatigue. I mean, if you have a hemoglobin of 6, for example, and you correct that and fatigue goes away, that's a very clear symptom. But a lot of people may not have any cardinal investigations that would differentiate that. People have come up with multiple markers that can help differentiating that, and I've listed some of them. These are many inflammatory markers, BNP, the N-terminal BNP, high sensitivity cardiac troponin, and other specialized markers. But none of these are, or hardly any one of these are in common use. They're not a part of routine blood testing, so you won't be able to get them easily to understand that. And in any case, it is not a very clear-cut association between any one of these markers and long COVID. One of the problems is that the pathogenesis of long COVID remains unknown and understudied. There are a lot of studies going on, but we haven't come up with why this happens. There are many theories about a pro-inflammatory milieu in the body, a highly thrombotic state, and so forth, but we haven't come up with the clear pathogenic mechanism for developing these. And the symptoms are so varied, it would be difficult to come up with a single pathogenic mechanism for all these different symptoms which affect so many different organ systems. Similarly, the treatment is currently almost completely supportive. So other than getting vaccination to prevent that, we don't have much else to go on at this point in time other than giving supportive care, rehabilitation, psychiatric and psychological help, and so on and so forth. So in summary, the take-home messages are that the pandemic is not over, but I think it's not a public health emergency like it was even a few months ago or end of last year. It's nowhere near as bad as it used to be, but we still need to remain vigilant. The variants that we see, we need to continue monitoring them because they behave very differently, and if there is a major change in variants at some point in time, we need to be vigilant about that. Point number 3, or take-home message number 3, is that the boosters or repeated vaccination or regular revaccination certainly helps a lot. And we should really consider that. There is clear guidance on that now that has been given out by the FDA and coming out from the CDC as well. Long COVID is real, it is common, but we know very little about it, and we look forward to seeing some more studies on that in the near future. One thing I did not touch about is treatment of COVID because of the lack of time. But if there are any questions around that, I think you asked Dr. Lin, and she answered that quite well about Paxlovid, for example. We use that. We have several studies published and in press, even comparing Paxlovid, which is nirmatrelvir with molnupiravir, and we have shown that former, which is Paxlovid, is much better. And which supports some of the earlier studies as well. But the difference or the benefit is limited to certain populations. So the population that needs to be given those drugs is people who have mild to moderate disease, who are at risk of progression to severe disease. In other words, they have at least one of the risk factors for progression. So if you give it to a completely asymptomatic person who was just diagnosed on routine screening, who doesn't have any risk for progression, it probably will not help. Similarly, I don't believe it will help in people who already have developed critical disease, are in the ICU and so forth. It is the middle population who are at risk of progression, who are symptomatic, where these drugs may help. One final word about, or second final word about remdesivir. And we have done a number of studies where we have not found remdesivir to be highly effective. I have withheld that publication because actually remdesivir had shown some worsening outcomes in the populations we saw, and I'm unable to explain that. So we're doing many more analysis to try to figure out why that is. So I personally do not recommend remdesivir at this point in time, but there are certain populations again where it helps. And we need to talk, similar to Paxlovid, where there's a risk of progression in mild to moderate disease or so. Ivermectin does not help. Azithromycin does not help. Steroids do not help. So if you do nothing else, please don't give these things to people with COVID. I'll stop here, and we'll be happy to take questions if the chair allows. Thank you.
Congratulations, wonderful updates, really enjoyed it. Just a couple of questions. We are still in the middle of doing this trial, phase 3 trial for Scopio. Scopio, this trial is multinational. It's being conducted in almost all the countries of the world. I am the PI here. So we have 5 centers in Pakistan. It's a phase 3 trial on Paxlovid. It's a placebo, double-blind, placebo-controlled. We are only using Paxlovid in outpatients. Inpatient people are excluded, rightly so, because viremia stays for a very short time, and you need to be viremic to benefit from antivirals. There is no point in giving them once the virus is cleared out. We did 2 studies. One is called PROTECT study. PSIM was the main, and Umar, I think, participated, Umar Center. We had 13 universities participating. This was comparison at that time. This was very early on. Hydroxychloroquine, azithromycin, and then there was the 3rd antiviral arm. And a 4th arm was where we collected everything. And aggressive treatment with everything, we don't know what worked, but that was, outcomes were better than this. But then one of the very fascinating studies that me and my colleagues did was Victory study, which was published in Frontiers. This study was in patients, critically ill people who were on ventilators, and we gave them very high doses of vitamin D. We did not check vitamin D. We got the national bioethics approval, local bioethics approval. So because we convinced them that this could improve the outcomes, and the outcomes improved, not only clinical outcomes. The cytokines were reduced significantly, all interleukin 12, 6, 12, and INF. They were all significantly reduced, but also interestingly, the cytokine gene expression was reduced. So it may not be applicable to the population in US or Qatar, I don't know, because here vitamin D is low, and we know that vitamin D is a master vitamin as far as immune system is concerned, because the conduction of the signaling conduction, because in COVID, virus damages, but more so your hyperimmune response damages. So there is malfunction if you have critically low levels of intracellular vitamin D in the immune cells. So that's our hypothesis. I wonder, and then since then, our local guidelines that we have, we are giving vitamin D as a routine. So I don't know if you have any experience or whatever.
No, there is no current guideline in the West that recommends or even is very seriously studying vitamin D at this point in time. But my philosophy is that if it's a benign thing, like vitamin D, and you're not giving intravenously in mega doses, then probably you might try that. So, yesterday we talked about first do no harm. So if it's not harming, if there's a potential benefit, okay, I mean, I'm fine. But then there's no guidance, or there's no guidelines that recommend vitamin D. And of course, hydroxychloroquine and azithromycin trial, not only every single trial that has been done showed no benefit, there are a few trials that actually showed worsening in those people. So that's very important to know. I've seen a lot of prescriptions for azithromycin, and people send me, because we have an ID group, people send me actual photos or scans of prescriptions written by some of the GPs in Pakistan, which are about 8 to 16 medicines for asymptomatic or mildly symptomatic outpatient COVID. So I would strongly urge not to do that.
This vaccine escape problem, because of the mutations and the new variants coming in. I know that Pfizer keeps on modifying the vaccine, and so does Moderna. Do you think is there any role of subunit vaccines or attenuated virus-based vaccines? Because I personally don't see any more role except for messenger RNA vaccines.
Yeah, so there were some trials for attenuated virus vaccines published, and they showed reasonably good results. Reasonably good results, but they've not taken on because you have very highly effective, easily manufacturable vaccines which were rolled out globally. I mean, you can't beat. So one of the first studies on this vaccine effectiveness in the US was my group. We published that in Annals of Internal Medicine. That was wild type virus. You had 95% vaccine effectiveness. I mean, that's better than any vaccine you know of in anything. I mean, of course, it went down with the variants and so forth. But yes, there is a role that you tailor it once the virus mutates. You have to look at the antigens or the surface proteins. But even if you don't do the newer subunit vaccines or these modified vaccines, even the original vaccines have been shown to help the subsequent viruses. I don't know how and why they help, but they've helped significantly. Thank you.
I think, yes, please.
Is there any information concerning comparative effectiveness of vaccines? Is, for example, mRNA better than other types of vaccines?
Yes, actually we have done the landmark studies published in the New England Journal of Medicine. Pfizer vaccine turned out to be somewhat better than Moderna. But the thought was that initially in the early days, Moderna was given further apart and the dose of Moderna was lower. So people thought that might be the reason. But in real life, real world settings, I think their effectiveness, not talking about efficacy, effectiveness is pretty close to each other if you control for the dose and the duration, the time between the two doses. Thank you.